Green ticket. Okay, dear colleagues, now I will present the next topic about the 3D fetal neurosonography. I think this is relatively new for all of you, most of you. I know, some of the participants here already used to do the 3D and used to do the 3D sonography. But for most, we need to start it from the early beginning. The fundamental in doing 3D sonography and why we are not doing 4D, 5D, and what is the most influential tip for doing the 3D ultrasound. So I think it is very clear for us that the vast majority of people, not only the outside of the medical terms, but also our colleagues, still very confused about what is 3D, what is 4D, and what is 5D. And also the patients. Patients is always asking to do 4D. Doctors, I want to do 4D to determine whether my fetus is alright or no. And it's conflictingly unrelated to that we are doing for diagnosis. So entertain and a diagnosis is quite a bit of difference term that we have to anticipate. You know, term of 4D is about doing 3D with the motion. Okay? 5D, there is no term of 5D in the scientific term or academic term. 5D is only in the term of entertaining. If we are using HD, the high definition machine, and we can pop out the image, and the image will look like this, the patients look like more happy, so we call it 5D. But is it has a potential influence for making a diagnosis? Yeah. How about 4D? Is it necessary for diagnosis? For fetal echocardiography, when we want to see the three-dimensional spaces X, Y, and Z with the motion of the heart, we need to use 4D. But the brain is static. Brain don't move. The heart moves. We need to find out the contractility of the myometrium. We need to find out about the valve movement so we can measure the cardio-morphofunction, the cardiac, and also the function, morphology and the function. So, in here, I will try to describe about three-dimensional neurosonography, and please tell the patients this is a three-dimensional and don't make them disappoint for them. So I will start from the early beginning. This is one of my favorite literatures for publications from the very, very early on, almost 20 years ago. 20 years ago from Wiku. It's a very nice structured journal or publications. We can see in here the functions for diagnosing using a three-dimensional is related to the four functions. Yeah. The first one is the multiplanar and the tomography. This is the one that we have to prominently subject when we are doing three-dimensional examinations for ultrasonography. And the other is for making sure the cranial bone and the structures is good, and then by rendering. And then also for making sure about the vascularizations. Yeah, we heard a lot about the vascularizations in brain previously, in the previous lectures, and then for making a volume measurement. I think this is the four most simple functions of three-dimensional sonography. So we will start from the early beginning, the most important one, the functions of viewing three three-dimensional ultrasonography, the multiplanar, and tomography. So if we cut the bread in slices, the coronal, axial, and sagittal, it's what we are doing the multiplanar. So plane A, plane B, and plane C is representing the three-dimension plane X, Y, and Z. So if you see a coin inside of the bread and you're slicing it X, Y, and Z, it look like what we are showing to you in front. And we are doing a tomography. It's different. It's like slicing the bread, yeah, with the same plane parallelly, yeah, moving forward or moving backward, and it is related to what we are going to see. How much the slicing that we want to use, and how much the thickness that we should use for the slicing. This is the fundamental aspect of when we are doing the multiplanar and the tomography. So please keep in mind for this. Now, I want to know whether this is multiplanar or tomography from the participants, the audience. Is it multiplanar or is it a tomography? This is the multiplanar. Yeah. The acquisition plane is here. The point of interest is here, with the dot in the fourth ventricle. So if we are making a multiplanar by making the point of interest in the fourth ventricle, the vestibule, what we can see in here, we can see the corpus callosum, we can see the cavum septum pellucidum, and for most we can see the fairness cerebellum. Very clear, and we can do the diagnosis with this. Previously, yesterday, I told you how hard we want to find the sagittal plane when we are doing abdominal sonography, because always the positions of the fetal head, instead of it is a head presentations of the bridge presentations of transverse line, we can only cut very clear in axial plane. So we are using axial plane to do the sagittal plane by using a multiplanar. And also, this is the coronal, we can also investigate also. But here we can appreciate most the sagittal plane by using axial for the first cut and using the multiplanar. Okay? So if we are talking about the demi-Walker malformations, we are talking about the Fermion hypoplasia, we are talking about the megacisternum magna, if we are talking about the abnormalities like a black cyst in the fossa posterior, we should make this plane by using the multiplanar. And this one, if we know that we only want from the axial plane move to the sagittal plane, we don't need to use the coronal plane. We can choose the multiplanar to become biplanar only by slicing A to become slicing C. We don't need slicing B. So we use this and we will see here. Very clear, the fairness cerebellum, the body is not disrupted and no angulation, like if it is being pushed by the back cyst. Okay? This is the point of interest, and this is, if we put here, yeah, in the cavum septum pellucidum, we can see it will be the dot come out from the tip of the genuine of the corpus callosum. Because the corpus callosum is the roof of the cavum septum pellucidum. So this is a study from PILU publications that we can see what here to compare about how clear we can see between transabdominal three-dimensional neurosonography and 2D direct transvaginal. How can you appreciate this? Yeah, between the direct two-dimensional 2D direct is more we can appreciate. It's clearer. So what is Prof. Leonard Poon has told to us, Professor Wu Xing also, use transvaginal oftenly, from now. So we can see the morphologically, anatomically is very clear compared to the dimensional using a transvaginal. But we don't know, the machines now is getting, technology is getting higher and higher, and everything become almost comparable. So this is a 2D direct sagittal. If you want to see the sagittal and parasagittal, very clear about the dilation and sensation. This is, you can see vermis, fourth ventricle, and brainstem. So here, 3 slices tomography is like a slicing with only 3 slices, -1, +1, and we can see where is the most good and clear resolution, and we can definitely appreciate the picture. So if we make a 7-slice tomography, actually we don't need to use this, but only to show the most clear picture is on the center, so that you can see the slicing. So you see at the center point representing the middle slice, and the before is representing on the left and on the right side of the brain. If you are slicing sagittally on the axial plane. So this one is clear. Okay, this one is corpus callosum, and this one is vermis, and you can measure the angle. Some of you maybe asked me previously, how can we appreciate the angle of the brainstem with the tentorium and brainstem with the vermis, to make sure whether this is a black cyst, this is a Vernian hypoplasia, and this is a Bailey Walker malformation. Okay. So now the higher technology will make us easier to measure the compartment of the brain. The major compartment for measurement is the transcerebral diameter, and the cisterna magna for posterior complex, and for lateral complex we can see the Sylvian region, and also the lateral ventricle posterior, the posterior horn of the lateral ventricle. And maybe later on the AI also can measure the angle of the Sylvian vision. Maybe Leona's team already made AI for measuring this, for the CNS, not only cerebellum and then the cisterna magna and ventricle posterior. The angle also come out directly, automatically. Maybe for the not in very long future, maybe in the near future. This is also can be done by the very nice machine from Mindray. If you love to see in the live demonstration after this and previously in the hands-on, how the machine can help you faster and easier to get the measurement correctly. And this is the tentorium, this is the vermis. You should very notice the anatomical structure, and you should remind what is the point of interest of each of those. So in this case, you can see in the axial plane, in here, we cannot see the vermis. Here we can see the vermis, but in the this picture, we can see in the posterior is very large, the cisterna magna, but in here is also very large without the vermis. How can we differentiate the diagnosis? Is by doing the sagittal. So if we are seeing in axial vermis, we see cisterna magna, and we maybe this is a megacystal magna. Still, we need to find out by examining the sagittal. So, sagittal slicing of plane is mandatory if we are having abnormality in posterior fossa. And how about the coronal plane? We are seeing also here in the agenesis of corpus callosum, there are two types. Simply two types, complete and partial. And how we can differentiate it? Instead of only seeing in axial plane a teardrop appearance, here we can also see in the coronal section, we can see how it looks like the horn of the buffalo. In here. It's very different with the partial agenesis of corpus callosum. And if we want to make it more clear, if we want to make it clearer, so we have to do the color Doppler to see the pericallosal artery and also to see the callosal marginal artery. So if we found abnormalities on the anterior complex, it is also very important to do 3D neurosonography for having a mid-sagittal plane and also the coronal plane. So for the first tips is you must really keen on noticing the anatomical shape of the brain by the plane of the axial, plane of the sagittal, and the plane of the coronal. And then the next tips about the preset acquisition and post-processing. Poor 2D acquisitions. If you want to do 3D neurosonography, you should know the two-dimensional very clear in the appearance. Because if you are already make the acquisition and click the button, the 2D is not clear, that's waste. It's not useful. It's a waste. You cannot find a very clear picture. So you have to make it very clear 2D, and for automatization you can choose the Sub-Spesialis, or maybe in another machine, type machine, maybe have a different button. You want to do the surveys, you choose the render. You want to do multiplanar or biplanar, choose the button for multiplanar, or only single slicing A and C, but with some sort of thickness, using an omni-view or CNBR in mind rate. And then when you have to do the multiple slicing, parallelly, you should use the tomographic ultrasound imaging. And also there is a volume analysis here, and we can measure the volume of the brain. Previously told to be encouraged to do for the congenital heart disease. This one, the button. You should notice the button, Sub-Spesialis multiplanar render, TUI, or another machine, maybe a different button, but the fundamental is the same. The fundamental is the same, so you can make a very good picture. Post-processing, you can manipulate the picture by spinning, rotating, increasing the gain, by zooming, and other. You must be very familiar with that and practice a lot. So post-processing here, if you are choosing 3x3, we can only see 9 pictures. If we want to see more pictures, we needed to appreciate more pictures. We choose numbers, different numbers for them. This is an XYZ for rotating, sliding, and also for sliding. We also needed 2, and increasing the gain so that we can measure. Okay, this one is the acquisition window. What we are want to see, the radio of interest, it should be not very broad, but not also very tight, so that we can appreciate the target organ that we want to see very clear, like here, the fairness, the corpus callosum, and we can measure also the angle and so on and so on. So 2D main acquisition plane should be taken in very clear resolution. This is a very fundamental. If you want to do the 3-dimensional, you get a good 3-dimensional, good or great if your plane in 2 dimension for acquisitions is not a good resolution. So you should do that the best. Correct research, Spesialis or manually correct acquisition, yeah, and so on and so on. You have to do it by practicing a lot. Like Professor Liang has told, like playing piano, yeah, playing piano, your hands should be very familiar with the button. Okay. So now angiography. This is the next chapter after the multiplanar tomography. Yeah. In here we can only see about the pericallosal artery, and it's very hard to take by using a 3-dimensional. So it must be in a direct 2D plane for sonography. It's very hard to find like this, or a picture like this, because if we want to see the partial agenesis of corpus callosum, we should see the callosal marginal artery, and we cannot making this by 3-dimensional sonography. So there is until now some sort of minus of doing the 3-dimensional sonography. Okay, this one is from research also. How can we differentiate between the good corpus callosum and the agenesis of corpus callosum by examining the pericallosal artery and also the callosal marginal artery. Okay, and technology is developed higher and higher. Like this is the gallant malformations. We can see very clear how the turbulence of the blood flow until it breaks on the sinus sagittalis. And we can also pick, like Leona said, we should define the brain, anterior, middle, and posterior. Yeah, so we can define the vascularity smarter than before, not the whole brain. Yeah, we can use the technology from the ultrasound. So the best way to get a clear mid-sagittal image is always in the direct observation, mainly in sonoangiography. So 3D is the backup plan for sonoangiography or for mid-sagittal incision. So this one, yeah, this is like a picture to describe, yeah, how if we have a fast X presentation or hand presentation, we see if we are making a slicing like here, we can only see about the transthalamic plane, transcerebellar plane, and transventricular plane. If you want to do the mid-sagittally, it's impossible to do. Yeah, instead of doing the transvaginal from beyond. This one, yeah, if we are doing transvaginal, this one axial become a sagittal, direct sagittal by 2 dimension. And the next chapter is about how you are using the render for surface and for the bone. Yeah, we can see in the transabdominal ultrasound, in axial plane, if we are putting the dot on top of the corpus callosum or maybe cavum septum pellucidum, we can see the anterior fontanel. And this is maybe have a beneficial to determine craniosynostosis or maybe some sort of the bone anomalies like thanatophoric dysplasia and other and so on. And this one also from Risuko. Yeah, Risuko make many publications about the neurosonography. She's very focused in neurosonography. I really appreciate that. And we can see also here for the spina bifida, what we are using for the 3-dimensional is to notice about 3 important part of the vertebrae of the spine: the body, and then the wing, and then the connection between wings, between the left and the right wings. So 3 parts you must appreciate, you must investigate. Yeah. This one, this is the wing, this is the connection between wings, and this is the body. So if we are using the OmniView or CMPR in mind rate, we can appreciate it, yeah, like here. And for a better view, we can see a multiple slice here. With using the OmniView or CMPR, we can see here the wings, we can see the body and the connection. So if we are seeing like this is a very beautiful, yeah. But if we are cutting it axially, we also notice it. Where is the wing? Where is the corpus and the body? And where is the connection? Yeah, this is a tomography. I will make it fast. Here we can see the skin is very good. Yeah, very smooth. There is no like hole at that. Yeah, but by using the tomography or the OmniView or CMPR, we can see if there is a problem like this. Yeah. Okay. So seeing for the open spinal bifida by only seeing the skin is sometimes very hard if we are not seeing the bone, the vertebrae. So this is a little bit playing by using the slicing that we can see here, rendering for seeing the vermis, the foreventricle, and we can also see the tentorium. We can measure the vermis, and we know if this is 29 weeks of gestational age. This is a chart, the growth chart, and this is a normal development of the vermis. Yeah, so we can use this also in rendering, but not in the standard protocol. Yeah, not in the standard protocol. So we're using a transvaginal sonography superior when we are using transabdominal superior if we want to see the spine and if we want to see the cranial bone and sutures and head presentation. Transvaginal is superior for making a render image. The last one, the volume analysis. You can see here measuring the placenta and measuring the volume. Yeah, okay, VI, like this. I'm going to make it quick, the placental architecture. This is Epstein anomaly, and we would like to see how is the volume on the brain. We can see the volume of the brain is shrinkage, is lesser than the normal one. Like, I don't know, in the Leona's slide, there is no Epstein anomaly, there is only hypoplastic left heart syndrome, transposition of great arteries, but this is just before I went to Malang, yeah, about 3 days. 3 days before I went to Malang, I see an Epstein anomaly and the brain is shrinkage. But this is actually the hard one, yeah. I have to measure it 30 degrees by 6 times, you know, next 6 times, and you get the volume. But now, I see from the machine, from the mind rate, only 1 click, and you see the volume. So this is the easy way, and previously is the hard way. It's up to you. You want to do the hard way, as I do, or you want to do the easy way. Okay? This is a 3-dimensional sonographic measurement of the normal fetal brain. You can use this chart to interpret the measurement. This is also, we can use volume for the ventricle. So guideline, we should know the guideline, 2007, Pilu and colleagues from the ISOP made a 3-dimensional ultrasound examination of the fetal central nervous system, a guideline. Always start with a good 2D capture. Direct 2D is always better, but sometimes it's difficult. So for the backup, we're using a 3D neurosonography. The clinical implication for advanced technology is still less immediate, but should not be underestimated by the experts. And this is the newest one for the standard from the ISOP. You can see here, yeah, very clear, the step-by-step. Jadi kalau Bapak Ibu sudah mau 3D yang jelas, 4D yang jelas, kalau tadi kan 4D karena ada gerakan, itu mesti betul-betul ada jarak, kemudian kelihatan dahi, kelihatan hidung, kelihatan mulut, kelihatan dagu. Baru kita bisa mengapresiasi Karet skornya berapa skornya. Jadi sebagai penutup ya, bahwa ya for the take home message, lupa saya bahasa Indonesia lagi ya, nanti gak direverse. For the take home message, you should say the anatomical shape of the brain by 3-dimensional in your mind. If you want to carry it axially, mid-sagittally, and coronally, what we are going to see, we have to bear it in our mind, and we have to have a good machine. We have a proper acquisition and proper post-processing. And the last but not least, practice will make perfect. Thank you very much for your kind attention. Maybe this little topic can be helpful for you to increase your standard of practice daily. Thank you very much. Thank you. Assalamualaikum.